All right. Awesome. Okay, welcome to Think and Drink number 10. Well, I just realized I need to share the screen too. Let's see. Okay, you guys can see this? You guys can give me a thumbs up. All right, perfect. Okay, Think and Drink. Oh, I didn't even change the number 9 to a 10. That's how sad it is. It's like I don't want to change it to 10 because this is the last one, but yes, it is the last one for now. Think and Drink number 10, caring for concussions. Okay, so we have two really good articles out here that kind of look at different aspects of how we manage concussions and how we diagnose. These are relatively recent articles within the last decade, but it really does clear up a couple things that we should, as clinicians, kind of demystify some of the old principles or old philosophies on how we manage concussions. So this is definitely something that I think, as we get more into the discussion, I want to hear you guys' perspectives and your experiences on just managing concussion cases. So I'm really excited for this one. As usual, we're always going to be discussing about a current peer-reviewed journal article related to sports medicine with other fields of healthcare. We're going to evaluate the evidence in the peer-reviewed journal articles. We're going to compare the evidence to our own clinical practice to see if we need to bridge any of these performance gaps. And last but not least, we're always going to have a great drink and think responsibly at the same time. So we have no disclosures or conflicts of interests. And if you got a drink in your hand or with you, cheers to our last one for now.
Cheers, Phil.
Got a good youngling from Pottsville, Pennsylvania. This is like Steve Bartlinski's and Jill's favorite beer, apparently. So
nice.
Try it out, and all of a sudden it made its way to Florida. So I'm going to try this out. But yeah, this is good. Okay, I know we have, let's see, I think everyone pretty much knows each other, but we could just do a quick introduction. So my name is Philip Ting. I was physically at LGOST, and now I'm a PT student at Florida Southern College. Anyone else want to chime in and introduce?
I'll go, Phil. Scott Zimmerman, work as the athletic trainer at Archbishop Mitty High School.
Hi guys, I'm Parker. I'm still at LGOST, and I am responsible for the Aquamate Synchro team and SGSU Swim and Dive team.
I'm Audrey. I am a recent grad, ATC, and yep, that's all of my affiliations right now.
I'm Jendo, or Jessica. Jendo is my nickname. I'm at LGOST. I just completed the sports physical therapy residency there, but I'm a PT.
Congrats on completing your residency.
I'm Isabel. I'm an athletic trainer in Tampa, Florida, and I am currently now at an outpatient orthopedic facility.
My name is Josh. I'm currently an OT student through WashU in St. Louis. I'm back in San Jose doing an online telehealth clinical with transition in through St. Louis, Missouri. So, yep. So somewhat related to PT, my field, but it's very much.
Awesome, cool. Thanks for all the introductions. Now we kind of got to meet each other, but yeah, let's get right into the articles. So, The first one I wanted to talk about is the study done by Dr. Letty. The study was titled Early Subthreshold Aerobic Exercise for Sport-Related Concussion. It was a RCT, and I thought that this study was done very, very well, especially how they explained it in the article. So they wanted to really see the effects of implementing aerobic exercise within the early stages of sustaining a sport-related concussion. And so we look at how the study was done. They had a good sample size too. They chose people from, 3 U.S. university-based outpatient concussion management clinics in Western New York, and then there's 1 clinic in Canada. I'm trying to see if I think they had around 100 subjects. Yeah, they had around 100 subjects in the study that were analyzed. They had 165 that were assessed for the eligibility for the study, and after going through the exclusion criteria, they were able to randomize. It says, they were able to randomize 113 of those subjects into 2 separate groups. So in the study, they were comparing the effects of aerobic exercise to a placebo intervention, or just an intervention, and they pretty much use stretching as their intervention for a comparison. But the results from here, it looked really promising that it is safe to do. It is safe to have patients go through an aerobic exercise bout, and to see the symptoms go down comparably to the stretching protocol. I thought it was something that's just it's really novel. Like, we would always tell patients to rest or to try to stay awake. Like, these are like the old school phenomenon, or the old school ideas of when we're managing concussions. But now we're seeing all these different studies coming out, especially for something that's just, hey, like, we should consider raising your heart rate in order to diminish some of these symptoms. This is definitely something that's really cool. What are you guys' thoughts on the study?
I've kind of played around with the idea of using some sort of submaximal exercise for kids, but so like one of the exclusion things too, they talked about ADHD being one of those exclusion ones for their study. Mm-hmm. And I would say a lot of my kids have ADHD, and so they may not be appropriate for it. And then you also look at the number of symptoms that they're having. I think the study talked about waiting 48 hours before you begin that, and that's typically what we'll do. But we also need to get approval from the doctors, and a lot of docs aren't on board with it. So
right,
I get hung up.
Yeah, do you feel like this study, like, even though the study was published, do you feel like, how long will it take for physicians to kind of adopt this new idea into their practice?
I would think it's going to take them a while to really get up on that, or have to see more studies or more results from it. I do find the kids that are kind of borderline, and we do start the return to play progression, they seem to do very well once we start doing some exercise. They actually get better a little bit quicker. So, and that's not even they're using their protocol that they use. Yeah. So I definitely see some benefit from it. It's just getting the doctors involved in it, I think.
Yeah. Yeah, I think what I found interesting too in that exclusion criteria was they excluded the people that were that had the ability to exercise to exhaustion without symptom exacerbation on the first visit. I thought that was interesting, because it's, if you had someone that that was fine exercising, and you get their heart rate up to 80% of their max, and they don't feel exhausted, it's like, what do you do next? And I feel like that may be the reason why they had to put that in the exclusion criteria, because then it wouldn't, they would essentially be outliers in the study, I would be assuming. I don't know what your guys' thoughts on that.
I was surprised too. That number seemed higher than what I anticipated. I didn't think 39 of those people would be able to get through it without having some. So I was surprised by that.
Yeah, 39 had normal exercise tolerance. Are you guys familiar with the Buffalo concussion treadmill test? So the Buffalo concussion treadmill test, it's a 20-minute test, and you have a heart rate monitor, and you're on the treadmill, and you start with 0 degrees of incline, and then I believe it's after each minute you need to report an RPE scale and then a Likert scale. You're reporting those symptom scores, and then after each minute you're gonna raise the elevation to a degree on the treadmill, and then you pretty much max out at 15 degrees of elevation on the treadmill. So in a sense, it's kind of like a progressive overload with the Buffalo concussion treadmill test. And I thought it was appropriate for what they were trying to do, as far as figuring out what kind of aerobic exercise they would do for their intervention. But yeah, this was like the first time I've heard about the Buffalo concussion treadmill test, and I had to look up the details.
Yeah, I think the key is keeping that heart rate at a lower level, so you're not maxing them out at all. You have to maintain that. They've also developed a bicycle one too.
Oh, okay.
So that was a new one that I'd seen.
Do you know if like the bicycle test also has like some sort of elevation variable, or is it just like a resistance? Or
I think it's resistance, but I haven't done that much research or seen that much on that one.
Gotcha. Okay. Yeah. It looks like Josh also joined in. Let's see. Yeah, we got a quiet group today.
I know, huh?
Sorry, I couldn't figure out how to make my window pop back up. I couldn't see it.
All good. Yeah, I think I'm trying to see with the. Yeah, I just think like the study was like the way that they shared their results and their discussion pieces. It was pretty valid. Like there wasn't anything that made me question. I mean, other than just like their exclusion criteria, but it seemed like this is just like the good start to see where else we can evolve the concussion management, especially if this intervention definitely shows good positive results on symptom reduction.
I'm curious, what they said like 13 days was when those aerobic people started to get better, 17 days for stretching. That still fits in that timeline of concussion healing too, right?
Yeah.
So curious if they had somebody who doesn't do either of those, do they still end up in that same time frame? And then we could get into, do they do impact tests? Do they do best tests? Do they do other stuff? And what are those results?
Right, yeah. Yeah, I don't. Yeah, they didn't mention much about the protocol after they had their symptoms. Um, After their symptoms were like getting resolved, like they weren't talking about any other like return to play protocol or anything like that. But I would assume it's just because it's all different amongst all the subjects that were involved. But I wonder if like if would this change like in the future would this change how we would see return to play protocols?
I feel like some of the like I went to the San Francisco Giants Sports Med Conference, the last one they had because they've been skipping some years. But and one of the head athletic trainers, he talked about their return to play or their concussion protocol, and kind of similar to the study after 48 hour or 48 hours, they have them starting a sub threshold like cardio program on a bike. He didn't necessarily talk about how they like scientifically accurately objectively determined their sub threshold. Like I don't think he didn't mention doing the buffalo concussion test. I think it was more just like subjective and just like monitoring like how the time it took for them to get to symptoms. Like arbitrarily they said day one they were just on a bike for like 10 or 15 minutes, and if they could tolerate that then great, if not then stop them when they started feeling symptoms. And then each day was kind of progressively adding a little bit more cardio if they could tolerate it. So so it seems like at like the higher levels there's already starting to implement this research, which is kind of neat.
Yeah, and it almost seems like they kind of play it by ear each day, just depending on what the patient presents itself. And it's interesting because in this study, I think it's I'm trying to see if I think the participants were more all over, right? I don't think it was mostly adults in this one, right?
No, I think it was adolescents still, wasn't
Or
it?
adolescents, yeah. Okay. That's right. Well, I'm actually gonna.
I'm trying to see if I can find it.
Yeah, mean age was 15
yeah,
in
13.
both groups.
Right. Yeah, ages 13 to 18. But it's interesting because even in like the high school or the collegiate level, or correct me if I'm wrong about the collegiate level, but definitely at the high school, we always have to go with like this, or we're expected to go by the CIF protocol on a return to play guideline. But this study shows even like adolescents, there's a great difference of symptom reduction with an aerobic intervention. And it just seems like now that I think about like the times that I've had to manage concussions at Willow Glen High School, it's like, are we behind the times, or like we're always going to be behind the times? But this is something that like, yeah, we should start implementing current evidence and being able to tell people who are making these decisions that aren't keeping up with the current literature, like there should be some sort of leeway that allows us to use current evidence to justify our return to play protocols that's better for the patient, and not because it just has to be standardized across the board or trying to make it fair. Like I think it's important to really recognize like how beneficial it is for someone's health.
Do you think, kind of like Scott mentioned earlier, like do you think that starts with educating the physicians, right? Because like he said, like at the lower levels, the high school athletes, younger athletes are going to go see their primary care physician, right? And then they're gonna kind of dictate like, oh, you should do this or not do this, or right. So do you think starting there is like the first step to achieving that, or do you think it needs to be even bigger, like start with CIF, like if it's a procedural rule thing? Do you think it needs to start there?
See, I say this with caution because it's like, if I go on record and be like, yeah, we got to educate the physicians, but this is funny because the article is written by physicians, right? There's actually a lot, like actually all of them, except for the last 3 authors of this article, they're all physicians. And like but I also think like when CIF, well, if the CIF created the return to learn and return to play protocol specific for California, I mean, there is a sports medicine advisory board that really oversees this. So I think either way, it's just important to really communicate, not necessarily educate the physician, but being able to share these articles and say like, hey, like this is a pretty good RCT that we saw. Like, what do you think? And I think what's really nice is that depending on the physician you work with and who you know and how well that they can trust you in terms of making that clinical decision, you kind of have to hold the reins and find what's best for the patient. If it is the aerobic exercise, then I think it's worthwhile to really sneak that in somehow without having to overexert them and something goes wrong. Because even there, they even mentioned in the study where if you did do some sort of aerobic intervention and all of a sudden your symptom scores spike up, then maybe that might not be the right intervention at the time. Let alone even in the results, they said 50 of the 52 did report symptoms decreasing, but what happened to the other 2? So even though it may seem a little bit insignificant, there still is that outlier. But yeah, to answer your question, I think it's just to really share the knowledge. Like at the end of the day, we're all clinicians and we all come from different practices and different fields. But I feel like medicine is still the same regardless of who's taking in what part, if that makes sense.
I would say too, it's very important to see if you can reach out to those pediatricians and talk to them a little bit, developing that open communication with them. I get such a wide range of responses for concussions that we send kids for. And there's some doctors that still are like, nope, you're not doing anything for a week. And there's some doctors who are like, I'll leave it up to the athletic trainer. Or some doctors are like, it's so across the board, this keeping that open line of communication is such a huge thing.
Right. I drink to that, Scott. I think it's just like there's physicians that just say, hey, like sometimes they're not even clear on their doctor's note, and they would say, oh, no activity until this date. So then the patient and the parents would always think, well, until that date, is he free to do everything else or not? Like, and that's where it just makes me wonder what is being discussed in their realm as far as like pediatrics go. Like it's not that I'm skeptical of what their care is. It just makes me wonder in a sense.
I have a question. I guess it's more primarily directed towards Scott. Do you work with, I believe you were saying you work with high school athletes and
Yes.
I guess more pediatrics, is that correct?
Yes, correct.
So how are you bridging that gap? So you're talking about, some pediatricians or that are, I guess you can say maybe primaries for these kids that you're working with. How are you bridging that gap with them? Are you, seeing that they possibly have this concussion, you're, talking to the parents, go ahead and take them, to your primary. Are you sending them with articles? Are you saying sending them with paperwork? You know, if the doctor were to say along the lines of, you know, complete rest, you know, can you go ahead and, you know, give them this kind of information? Or is it something you get an email, you send them the information? I understand I sent this, you know, player with you, you know, via the parents. Please review this documentation so that we can all be on the same page.
Yeah, we have probably like a 5-6 page packet that we send. You know, part of it's, you know, your emergency care stuff that we look for. We usually will send our evaluation. I'll send my scat with them so the doctors can take a look at that. We use Sway Balance. I may send a copy of that with them. And I also send it with them. We have a protocol for return to play, and the doctors have to be aware that this is what the kid has to go through. So it's like a 8 day progress. So they have to pass through us regardless of what they say. And then we also have a letter that we send with them that they have to say either they're concussed or they're not concussed. And then we make it clear that they have to go through. They have a spot where they have to sign where either they can begin the return to play protocol, or they can begin the return to play protocol on so-and-so date. So we try to give as much instruction to those physicians as we do. So that's one way we reach out to them. And we'll send that packet, and still, I would say probably half the time we get like the little notepad back, say, nope, can't do anything. So it's a little frustrating when we make that effort and we don't get much back.
It sounds like you got a really good handle on it at the high school that you're working at, and I guess it's just the other piece, the other portion, you know, the piece of the puzzle that's kind of not on board quite yet with everybody's pediatrician.
Yeah, I'm old enough where I've been around and I've seen enough, I've known enough of these doctors, and part of me is, if COVID wasn't going on, like the summer, I'd like to spend going and visiting their offices and introducing myself so they can get to know us a little bit and understand what we're trying to do, and maybe have a conversation about some of those things. That's, hopefully we get out of the COVID stuff and we can do that at some point.
Yeah, I agree. And yeah, and I've had experiences too where it's like I would send all the paperwork and just showing, hey, like I've done all these different tests. And then I distinctly remember there's this when I asked the patient, like, oh, how was your experience with seeing your doctor? And the patient's like, yeah, she saw your paperwork and it was just super, like, why do I need to see all this? I'm going to clear him anyway. And so in my head, I'm like, then what did I do all that for? It's just kind of like I know there was like a purpose to doing all that and just showing objective measures, but I feel like as a healthcare physician who if you hadn't seen your patient in a while, and it's good to hear from another healthcare practitioner, like what you've been following up with the patient, like it's good to see how they've achieved that progress, so that they themselves can realize, oh, there's a way that I can better my practice without having to have my eyes on a patient the entire time. But I think, but yeah, just that experience alone, like I definitely remember it's like man, I thought I thought I was like proving my value as an athletic trainer, like, oh yeah, this is all the things that we've been going over and learning and applying it now. And then just to hear the pediatrician say like, oh, well, cool, thanks, but no thanks. Like it was interesting, but yeah.
And we still have to respect their knowledge and where they've come from and what they've done. And maybe they're old school and do things a certain way, and you have to respect that. So
exactly. Yep. Awesome. Anyone else want to add to the discussion? All right. Yeah, I thought, this was a good article, and I would definitely share this more. And especially, this was published last year in February of 2019, so this is fairly recent. And I'm curious I'm pretty excited to see more of these studies coming out to show how aerobic exercise can really influence someone's status when they've sustained a sport-related concussion. Okay, so the next one, this one's done by Michael Barlow and his colleagues, and the title is Differences in Changes in Change Scores and the Predictive Validity of 3 Commonly Used Measures Following Concussion in the Middle School and High School Aged Population. And so they were really just studying these different tests that are commonly used when we're managing concussions. So they're looking at the post-concussion syndrome and the post-concussion symptom scale. They were looking at the balance error scoring system and looking at the 5 subscales of the impact testing. I think this study was, I don't know, I think it was interesting enough to really cement the fact that you can't really have one test diagnosing a concussion. And I think it's just because there's just not enough, I guess, statistical power to really show predictive validity for any one of these tests, but to do a battery of tests, it's useful. But it still kind of left me with a question mark on like, well, how many tests do we need to do? Like, well, what's a good number of tests that we should be employing with our patients when it comes to diagnosing or figuring out like the prognosis of someone's concussion?
I think what was interesting about this article was, or this study, I guess, well, it was retrospective, right? So they're going back into data and charts and finding athletes or people with concussions who specifically met the criteria of having all 3 of these tests done. So one, you'd need like a center that does impact testing, because not all places do impact testing or can afford it, right? And then the other thing is the 3 different outcome measures they were using, like the BESS is just for balance, right? And then you have this neurocognitive, very long, complex test in the impact testing, right? And then you have the PCSS, which is more just like a self-reported like symptom scale, right? Like they kind of rate, do they have headaches? Do they have, all these different symptoms? So they're all kind of looking at different things. So I feel like it's hard. It makes sense that we need to use a battery of tests, one, because these are all kind of measuring different things. And then 2, just like the complex nature of concussions, right? Like people present with different symptoms and those symptoms change within a week or 2, right? Like some start with headaches and nausea and vomiting, and then it progresses to migraines and reading difficulties, right? It's just so varied, and it varies so much from person to person that as much as we try to like make this as objective as we can, the more we're learning about how to manage concussions, it's so difficult just because of the nature of this injury, right?
Right. Yeah, and I think it definitely makes me, or it helps me recall when it comes to concussions, there's multiple domains, and it's a multifactorial. I almost called it disease. Well, it's like a multifactorial injury, and we have all these different domains, and it's good to have a battery test that addresses those domains just to see where someone is at in terms of their concussion state. And sometimes but we also run into the obstacle of whether if a test is more on the subjective side or the objective side, and looking at each of those domains. So my question is, are we still looking at enough tests per domain or per factor going into the concussions, right? We may have the best test for balance, right? But would we need to incorporate another test, maybe the sway test along with the best test. That's something that's just like I'm curious as to like how much are we doing too much or are we doing too little when it comes to managing concussions?
I think if you look, this article was what, 2011, so it's fairly dated. It's almost as old as I am. But if you look at like where we are now, think about when you're doing a concussion eval, how many people are using bombs, how many people are using ocular stuff. All that stuff plays a huge role now versus back when this article was written, it was barely on the radar, I think. So to me, that's a huge part of it. So yeah, I think we do need, and if you look at concussions, I was talking to one of our team docs today, and we have a kid with a concussion, and he was talking about his other physician. He's like, "You're not a concussion doc, or else you're doing a VOMS test." So that's a huge part of it now, and how much of concussions are all related to those systems a little bit more. I think we're finding that out more and more. So I think you have to have a big part of these, a big battery of tests, or be able to really identify where you think they fall based on some of their symptoms.
Right. I just feel like my concern is just with all these tests, there's always going to be like, we almost have to accept the fact that there's going to be a huge variability of practice when it comes to managing concussions. Like, I wonder if there will ever be a time where it's just we all, like, all of us will, well, I guess now that's just a loaded question to think about it, because everyone's coming from different backgrounds and resources. There may be places that have a lot of resources or not a lot of resources to do certain tests, but there should be like a standardized, or there should be a good number of, or a good set of specific tests that everyone should be able to do regardless of resources that would hit all of these domains.
Yeah, Scott, I agree with you with the, what you're saying about the VOM stuff. I started to get exposed and experienced with that in grad school, and I wish we used it where I'm at now. I think it's a really valuable tool, and I'm seeing more and more, even if we don't use it in our rehab sense, I'm seeing more of our sports docs use it as various assessment tools, getting, your horizontal and vertical saccades and getting some horizontal VOR and stuff in there. And obviously you can take that and go down a rabbit hole of how you should treat based off your findings in all the different domains. But I think it's really evident, especially if you were able to get a baseline on a kid and do a VOM screen. If you're watching their vision and all of a sudden they have a hitch they didn't have before, something happened. And the kid may be talking and acting completely fine, but something's not right. And it's something a lot of these tests would never catch. So that I definitely agree. I think that's a big part. And Phil, you're saying, should we use multiple tests from each domain? And I don't know. I think at that point you're almost trying to go find an issue that might not be there. Maybe the best isn't the best. Maybe it's not objective enough. So the sway would probably take care of that issue, because you're going to now rely on a computer or the iPad to do that for you. You're at least going to have that consistency, and it's still going to give you a decent balance, assessment. But yeah, I don't know. There's not one thing that's going to do everything you want. And that's the point, because even something as small as knowing the kid is going to trigger, hey, something's not right. Now, obviously that's not going to be a determining factor on his return. Okay, he's acting normal, cool, he can go back in. But I think that's something as small as just knowing that the kid doesn't seem right can be enough to hold him out from something and get more tests done. I don't know.
I think one of our docs, the term concussions are like snowflakes. there's no one alike. Everybody's so different in what they have, and so each kid you have to treat differently. And you may have a kid with the same symptoms as another kid, but that doesn't mean they're going to get better faster. You may have different treatment platforms that you use for them. So everything's different.
Right.
Makes it challenging, fun and challenging.
Yeah, and that's probably why they couldn't find any predictability, right, with these outcome measures. Like it didn't predict whether someone got diagnosed with PCS versus recovered, right? I think it's just because of what you said, Scott. Everyone's different.
Yeah, I found what was interesting. Like one of the findings they said, let's see, the second major finding in the study is that there is no evidence that a baseline score of the best impact or PCSS had the ability to accurately identify individuals who will be diagnosed with PCS. And then it goes down to saying that there was the area under the curve was 0.38. That was like a statistic that they used, which suggests that those with a higher PCSS score had a decreased likelihood of developing PCS. And these findings are counterintuitive, and it is unlikely that a patient with a lower initial PCSS score is more likely to develop PCS when compared to a patient with a higher initial score. So that, like, I think it's just, that was interesting that that was in the results. And yeah, it's just like, if you were to only rely on that one test, you may get that false positive or false negative, really. But yeah, that was pretty interesting. And then I highlighted the part where, I mean, they remind us in the discussions that 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 PCS is a syndrome, and that the physicians may be diagnosing, the physicians who are involved in the diagnosis, and when there's multiple physicians in that diagnosis, that's where there's just so much subjectivity to how bad is this diagnosis. So that's where things can kind of get a little gray and tricky.
Seemed to me too like the focus on the PCS seemed narrow, and maybe back at that time that was maybe the bigger focus. Like, let's look at PCS and let's look at the where they end up. But like nowadays, like I'd like to combine the studies and say, hey, let's take a look at somebody doing aerobic exercise. Let's redo that study and add some different methods of rehab and see how things progress too. I'd be interested to see how that would happen.
Yeah, that would be interesting to see.
All right, Phil, that's your first study you're going to come up with. Let's go.
Oh man. Then we'll do like a multiple satellite clinic and get everyone involved. Oh, let's see. Ross is in the waiting room.
Oh, get Ross in here.
Wow.
What's up, big man?
Hello, Ross. Did you read the articles? All right.
Nope, not yet.
Yeah, well, we were just talking about the second article, and yeah, I mean, I think it just goes to show with our discussion that it reaffirms we need multiple tests. We can't just rely on one. I think that was like the main point from this. I mean, I was curious, like, because they chose middle school and high school individuals, and I thought there would be some sort of, I guess there would be some sort of separation between the two groups, but I think they were just looking at adolescents in general. But I'd be curious to see like how different subgroups of adolescents respond to these different concussion tests, especially the ones that are subjective, and whether if there is some sort of, I mean, I would definitely imagine there's a lot of variability between the two subgroups just because of what they're able to understand. But that would be one heck of a study to really pull off in trying to get kids to make sure they understand the question before answering. All right. Any other thoughts about Michael Barlow's study?
How many people are familiar with the impact test? Anybody who use it? Ross, of course. At
San Jose State.
Yeah. And even like, to me, a lot of pediatricians aren't familiar with it. So I've been talk to my doctors, and they say, if a clearing physician isn't familiar with it, don't use it. So I find I don't use it as much as I used to, which is kind of interesting. I don't know if you guys had thoughts on that. Sorry, Philip.
No. That was a valid question. I'm glad you asked that, because it's, yeah, even like at a public high school, the chances of us using impact is very, very slim. And so, I mean, we kind of just have to use what we have, and yeah, I can only imagine, and that's really surprising if not a lot of pediatricians know about the impact testing, then how are we able to really share that conversation with physicians about tests of impact? So yeah, I thought, yeah, that was a good.
So hey, Scott, over at MIDI, does Dr. Blatz or any of those guys utilize impact, or do they just?
No, like I actually rely on Chris Chung mostly to
Okay.
interpret any impact tests that I have. I've gone through the ITAT training and all that stuff, but I still need help interpreting the scores and looking at them. So, but even then, it's a tool, and not everybody we're going to do it on.
It's funny you bring that up, because that's exactly who the only person I've really ever had, especially high school or younger athletes, do it through is through the West Coast docs of Segmenting and Chung. Other than that, nobody, so but I do know that just San Jose State utilizes it, things like that, but I think that's the separation, at least in our area, is that if it's funded through the school or the university or something like that, then it'll be done. But if it's at a high school that just has kind of patchwork medical staff, it's just not really an option.
Yeah.
So
I think you'd be better off saving your money on something else.
Hey Josh, what's it like over at San Diego State?
In terms of impact, or our total kind of?
In terms of impact, yeah.
We use it. So typically we do baselines on everybody that comes in, obviously, as part of their physical day, paperwork, all that stuff. And then we won't do it again until we're thinking that they're ready for clearance. Like, we don't use it as an assessment tool to see any of that information. So if we suspect a concussion, we'll do a scat, have them see doc, and then go through our protocol of progressive return, biking, lifting, back into a non-contact practice, all that stuff. And then we'll impact once they need to go back for clearance.
So it's way late in the stages.
It can be. Yeah, it can be, but our protocol can be as little as 6 days.
Oh, okay.
So we typically will have guys back. I mean, we averaged under a week last year.
Oh, wow.
So, yeah, take that for what it is.
Yeah.
I'm not saying it's pro or negative. It's just a.
Yeah. Interesting. Okay. Anyone else want to chime in on anything we've talked about? This will be our last call for our Think and Drink, our very last one for now. Yeah, I think, these two journal articles are definitely something that I feel like they show a lot of value in how we view concussions today, especially with the aerobic exercise as an intervention. And yeah, I think this is I'm pretty excited to see where the concussion studies are headed to in the next 5 or 10 years, and hopefully there is some change to what we do with return to play protocols, and maybe we see like when there's governmental affairs involved in seeing like if they're trying to dictate more of how we want to return our athletes or return our patients, it's there should be some flexibility with the return to play protocol, and it shouldn't just be as strict. You need to go by a time-based criterion, but it still always goes back to the subjective and objective measures that we see on a daily basis with our patients.
Yeah, I would echo that too. I think I'm curious to see how things progress. I find it interesting going to return to play protocol. It becomes such a process for each kid. And a lot of times after you get through the first couple of days, they fill out their symptoms and they're pretty good about it. And then after that, their symptoms become, okay, I'm zeros. Stop bothering me. Let me get back to play. So it's interesting how kids progress. And that's where I've gotten out of the habit of doing symptom checks every day. You have to kind of let the kid be a kid. And I'd be curious to see what happens in the future and how we progress through things.
Yeah, maybe it's not necessary to do a daily symptom check, or even the symptom inventory might be different in the next couple of years.
Yeah, and we create these protocols, but I think the protocols have to be the use of COVID, where like fluid, everything has to be changing as we go through things, and maybe not every person can go through that same protocol as somebody else.
Right.
So.
Yeah, and I think.
Sorry, Phil. I didn't mean to.
No, go for it.
I just had given you that average. So I pulled up our injury data from last fall. So we ended up having 13 concussions. We had a total of 69 days of out time per those 13 concussions. The average time of being out, so until they got back into a non-contact practice, was 4.92 days. And then days out and limited averaged 6.21, so under a week average for all 13 of those concussions last year. And our protocol is very, very, I don't want to say gray, but there's just a lot of wiggle room on stuff. A guy may have some minor symptoms or something, and he'll progress as long as they didn't get worse from the bike pre to post. Like I don't know, let's say it was a neck pain or something, and it seemed to be all musculature. Our doc was cool with it. He may still progress to the run, something like that. As long as it stayed exactly the same, there was no increase in symptom, he may be allowed to move to the next step. Now, obviously, he's not going to go back to contact or anything like that with any of those symptoms. He has to be symptom-free, pass his impact before he gets to the contact practice. But yeah, I was like, wait, is it actually less than a week? It was. So I had to go look it up.
Here's a question I got for all you guys that are actually, seeing a lot more of the concussions up front lines, things like that. Do you see a less hysteria over them as you did maybe 5 years ago, where there was that huge, just, oh my God, when the movie came out and everyone's like, oh, it's just CTE, brain damage, oh my God, all this other stuff, to where now does it seem like it's a little less stigmatized, as that this is going to directly lead to brain damage, that kind of stuff? Do you guys see a little bit less of that with some of the athletes, or do you still see that it's a high, a big deal, I should say?
Go ahead.
No, Scott, please.
After you, man.
Okay, this would be really, really, I think it really, for me, I wasn't really practicing much 5 years ago. That would have been the very beginning of my career as an athletic trainer. But I think for me, it's all based on how many the kids had. If this is his third, he seems to be a little bit more concerned about it, just because he knows potentially his career could be coming to an end if he gets like another one. Like, there's no set in stone. If you get 4, you're done. But docs start to get more and more weary the more your number grows. That's just my personal experience with it. On to Scott, your turn.
Thanks, bud. I would say it's definitely less hysteria. It's gone down. There's so much conversation 2, 3, 4 years ago, maybe 5 years ago about, CTE, you're going to hold them out, or we got to be, should we cancel football? Maybe football shouldn't be around. And now I think it's kind of everybody's understanding. I think having protocols in place and state laws and all that stuff has helped us kind of mitigate it a little bit. So I don't see it as much. Maybe it's because I'm living in a COVID world right now and I don't even think about concussions, but
probably true. So then that moves to the next question is, in the last few years, do you think the equipment's better, or do you think the education about concussions have gotten better?
I think the education for sure. Yeah, I would say the education, like I think the equipment is now just more of a gimmick. Like not a lot of people, or not every single institution has, like, let's say like the Guardian caps, or even like the weird neck thing that they put on that was inspired by the way
the woodpecker thing.
Yeah,
the
woodpecker neck collar. I think that's
yeah. What's it called? It's
it looks like one of those like those
goes around the back and
headphones, but you wear them on your neck. Like I'm trying to
talking about the Luke Kuechly thing.
Yes.
Yeah.
Compresses the jugular vein.
Yeah. That one seemed very gimmicky.
Yeah. That one was like it's interesting. But yeah, I think just going back to like the hysteria, I think people who aren't in the front lines are more hysterical than those who are than being on the front lines of when we see like an acute injury and there was a concussion. I think, and then the people who are further away from like the field or the court, they're all talking about like, oh, like, what happens to the tau proteins and all this stuff, and like they like go down to the microscope of the brain. But for us, it's just like, oh, we just follow up with our patients, and when we trust that and we trust what we see, then it doesn't seem as hysterical or insane when it comes to concussion.
Yeah, so is the technology better? I don't know. I mean, there's some cool things out there, like the helmet sensors that'll tell you when they get a certain amount of like force hit. Like, that's cool. Doesn't do much for the prevention side. Does a better job of telling us when something bad happens. We were this close to partnering with a mouthpiece company that we're gonna get free access to that data. I was super excited for it, and then COVID happened, and that ruined that. The Guardian caps, the research is not great for anything except limiting rotational forces. And even then, it only took it down like a tiny, tiny bit. I don't even think it was significant. And then helmets, they're doing more and more studies, more and more testing on them. That's only going to go so far. But then from our standpoint, the education of what can you do that will help. Neck strengthening. If you have a strength coach who works for the contact sport and they don't do any neck strengthening, you need a strength coach, or you need to educate your strength coach, because that's something that's free, that is the most valuable tool that we have in our toolbox as far as prevention and what you can do. But yeah.
Don't get me started on helmet sensors. I hate those things.
You actually have access to them, Scott? You have some?
Yeah, we got the Riddell ones. Our administration required us to do it, but all the research I have says they're not very effective.
Really?
I have had some instances where the sensor goes off, or I'll go check the kid, and it turns out, yeah, they possibly do. But majority of the time, you're getting false.
Gotcha. I've never got to use them, but I just thought it seemed like a cool idea. No hands-on experience whatsoever.
Yeah, we did a study with Stanford. We were part of their study for a little while on the mouth guard ones, but we only did it for a year. We didn't get any feedback from them.
Yeah, and if I remember correctly, Barlinsky was the guy who was the one who told me that they did all those studies at Stanford with the accelerometers and the mouthpieces and things, and they didn't really differentiate what were concussive blows or not. It just did give them an idea of what was a significant blow, but it didn't correlate with concussions and stuff like that. So, but I don't know. Maybe the data's a little bit better now. I don't know, but that was one of the things that I remember him talking about a few years ago. So no, so the reason I asked that is just because, like, I would say in the last 5 years, I probably have done less of actual true, like, covering games. I mean, I'm out there, but I'm not necessarily like the AT who's kind of the dude in charge or anything like that. I'm just kind of sitting back and helping out. And I just would say in the last 5 years, I've done less of the evaluating of the concussions, seeing them less. But prior to that, when I was at Willow Glen or things like that, it seemed like they were a lot more prevalent, and there was so much more just kind of focus on them. And so I don't know, it just seems like it's kind of mellowing out a little bit. So that's kind of why I was just kind of curious what you guys are seeing right now. If there are things that are kind of changing a little bit in terms of the intensity of just the scrutiny, I should say, from parents to the athletes to the coaches as well. So cool. Good answers, man.
I would add too, Ross, I think coaches are a lot more educated and you see a lot more effort on tackling technique more than anything now. I think that's a huge part of it. So I'm encouraged to see coaches like taking a step up. Overall, like, our football numbers are down. And if you look at most high schools, a lot of them are still down. I think that's still a reflection that concussions are an issue.
Sweet, man.
Yeah, I guess here's a final question for those who don't work with football primarily. Like, what are your guys' experiences with concussions, or like, how, like, do you guys notice any differences from, let's say, like, if you've had like a football experience compared to like the setting that you're in now? If you have any experiences to share, I'm just curious what you guys have.
I can share something so I'm just a new grad, so I haven't had any actual like on the job experience where I'm by myself, but comparing a football clinical rotation to my internship with a cheer and dance organization, like, cheerleading's pretty high prevalence of concussion, and I would say, like, they don't care about it that much. Like, not too much medical staff besides like the people who are there, including myself, but like parents to coaches, like, it just doesn't seem like, it seems like a non-issue. Like, so I wish there was more hysteria on that front over there, but yeah,
Like,
I feel like it's just
yeah.
varying by sport.
Huh. So you mentioned how there's not that much hysteria on that end, but like, how did that make you feel as someone who's now a clinician? And just like, do you feel like you wanted to do something to change that, or was that or yeah, like, what are your thoughts on that?
It might just be like, cheerleading, I think, is more of a newer sport, and the organizations that dictate their competitions or their practices or whatever may not be as fleshed out as something like football. Like, as medical staff at those summer camps and like day competitions, we do provide documents for parents that are like, it's all the heads up. It's similar to the heads up stuff, or it's just like informational things about concussion, symptoms to look for, when to go see your primary care physician. But, depending on the group or how serious they are in terms of competitive level, like, they may or may not care. And I feel like at a younger age, the higher competition level they are, the more likely they will just shirk the symptoms and be like, whatever. But if you're at the lower level, they like are much more conservative. They seem to care more.
I see.
So to follow up on the cheer thing, so I have a daughter who did cheer as a freshman last year, and I have 3 nieces that were cheerleaders all the way through 4 years, and then team captains and coaches afterwards. And part of the thing, I think, is the reason they aren't so much on the concussion thing is because I think it was last year was the first year it was considered a sanctioned high school sport by CIF. So they were always kind of put off to the side as kind of this, well, are you really a sport, or are you just like cheering on the football team and this kind of stuff? And so a lot of those injuries were, I mean, you could see they do definitely high risk stuff. The Flyers are obviously the ones that whack their heads the most and things like that. And but it was just kind of this thing that sometimes even the trainers were like, do we address this? They're not really an athlete. You know what I mean? So I think there was a little bit of that. That's kind of what I've seen, historically with that. But now I think since it is a sanctioned high school sport through CIF, I think it's creating a lot more attention, much to the dismay of, kind of the additional team to cover. But I think it's definitely something that's starting to pick up a little bit more momentum in terms of looking out for them and trying to provide more medical staff for them. So,
Yeah.
But
Yeah, I mean, like the events I covered were last year and somewhat of the year before. So, I mean, there's definitely a lot of changes happening within, like, it being a sanctioned CIF sport. Agree.
yeah. Scott, what have you seen over at MIDI?
We don't have cheerleaders.
Way.
Yeah,
Really?
no, we don't. But I can go back in my days when I was at Fremont High School in Sunnyvale, and we had a competitive cheer team that did a lot of the stunting and all that stuff, and I saw quite a few injuries from them back then.
Yep. Yeah.
They were definitely on my radar, and they kept me busy. I can get into the band too. Our band kept us busy too back then. So,
Wow.
anyway,
Yeah.
Audrey, what age group was the cheer team you worked with? Were they college or were they high school?
So the summer camps I covered were primarily high school and younger. None of them were collegiate level, so that could be part of it.
Yeah.
Yeah, I will say, like, now that you mentioned, like, your MIDI doesn't have cheerleaders, the clinical rotation that I worked at that did have cheerleading as a sport, they also happened to have like a really large performing arts program. And then so the AT there was also in charge of all the performing arts. So I feel like in that case, that's like a really good scenario for them. But then that's not always the case nowadays. Yeah.
True.
All right, man, that was a great discussion. I think we covered a lot of different aspects about concussions. I'm very sad that it has come to an end, but we made it a good ending. This was good, and I think what we'll plan on doing, I mean, we'll send out the surveys to everyone who's participated, and everyone's eligible to get one BOC Category A CEU. And what I think I will also do is just send out another survey just to kind of get your guys' feedback on some things that you liked about these sessions, and just what we can do to improve them. So the second time around we start this back up, we'll have a better chance. We'll have a better idea of how to make things run a lot more smoothly. And yeah, I mean, I think for the most part, I had a lot of fun doing a lot of these think and drink sessions. And I know, especially like Scott and Josh, who've come out multiple times, and I think you guys are pretty much now like deemed veterans of this think and drink series, and just especially everyone else who's come in to really support and be able to share their experiences and learn something from these articles that we come up with. It's definitely something that holds a lot of value in our clinical practice. And so I really thank you guys for supporting this. And I'm really looking forward to the next time that we start back up these think and drink sessions. So yeah, thank you everyone. I really, really appreciate it. And make sure to check your emails within the next 5 days or so, just depending on how busy I get with PT school and what Pocket's schedule's like. Pocket, you'd be okay with sending surveys for the last time? All right, we got a thumbs up. All right, cool. Well then, in that case, thank you. We'll see you next time.
Hey, Philip, appreciate you, man. You did a great job.
I appreciate you, Scott. All right, take care, everyone.
It's really cool. All right. Enjoy PT school, dude.
Yeah, keep those AT roots though, okay?
Exactly. I'll be disappointed if you don't.
Yeah, I got AT work. I got AT work tomorrow, so I already got lined up to do something. So I'm
boy.
always an athletic trainer at heart, no matter what.
Don't forget us small folk, Phil.
Exactly.
No, I can't forget about you guys.
All right, cool, man. Have a good one.
You,
Bye, guys. Thanks.
Thanks. Take care, everyone.
Take care.